next speaker. So our next speaker is Ravi Tiruvoipati. He's an intensivist working at the Frankston Hospital. He's currently completing his PhD at Monash University on investigating the effects and management of carbon dioxide in critically ill patients. Today he will be talking about the association of hypercapnia and hypercapnic acidosis with clinical outcomes in mechanically ventilated patients with cerebral injury. Thank you.
Thank you very much. This is, as mentioned, a chapter in my PhD, and I think it is one of the most important chapters. The PhD is mainly looking at the effects of carbon dioxide in patients who are intubated and ventilated in our intensive care units. And the hypothesis of this PhD was that CO2 would have different effects in different diagnostic categories. This paper looks specifically at patients admitted to intensive care with acute cerebral injury. Now, this paper was published in JAMA Neurology Journal in March this year. Some of you may have read this. And there was an editorial that was published alongside this article as well. The slides that I'm going to show are largely from that paper, and you're free to take pictures if you find it interesting. Now, patients who present to the intensive care unit with severe traumatic brain injury, stroke, or cardiac arrest are not uncommon in especially level 3 and level 4 intensive care units. There's not a lot of research that has been done looking at specifically how their CO2 should be managed while they are intubated and ventilated in our intensive care units. There are some guidelines that are published that help us in choosing a target for CO2, and these guidelines say that we should perhaps aim CO2s between 35 and 45 millimeters of mercury. Interestingly, these guidelines don't recommend a particular pH for this group of patients. And generally, most of these patients stay in our intensive care for a few days, if not rarely for weeks, intubated and ventilated. Now, these guidelines come from very low quality evidence studies as well. Most are retrospective studies with sample sizes somewhere between 35 and 200. What we do know is that whenever carbon dioxide level changes, at least acutely, it changes the pH as well. And if the CO2 levels stay high for a prolonged period of time, then pH tends to get compensated by an increase in the bicarbonate. This is quite important because someone who has CO2 with no compensation of, say, 55 or 60 may have severe acidosis, but if someone has that CO2 for a certain number of days, their pH could be quite normal. And if you want to correct their CO2 from 60 to 35 or 40, you could make their pH quite alkalemic, and that could be quite harmful for our patients. So our study focused on delineating the effects of CO2 and pH, and that's the focus of this particular paper. So as mentioned over there, the aim is to review the association of compensated hypercapnia, meaning high carbon dioxide with normal pH, and hypercapnic acidosis, meaning high CO2 with low pH, during first 24 hours of admission to intensive care in patients with acute cerebral injury. This is a retrospective study that looked at data over a 16-year period from 167 intensive care units across Australia and New Zealand. And we included all patients who were adults and who were intubated and ventilated. As mentioned before, we have categorized these patients into 3 groups. One group had normocapnia and normal pH. This group was considered as a reference group. The second group is compensated hypercapnia, where they had a high CO2 and a normal pH. And third group is hypercapnic acidotic group, with high CO2 but low pH during their first 24 hours of ICU. The primary outcome was hospital mortality, and we had a few secondary outcomes, including discharge destination, duration of ICU, and hospital stay. This is a retrospective study, and I'll show you the comparisons in a while, but retrospective studies have a lot of bias and confounders. So we used whatever is possible in the field of statistics to account for these imbalances, and we did assess the normality to start with to see whether the data is normally distributed or not. And if the data was not normally distributed, we transformed that data to ensure normality. We used group comparison. We used chi-square tests for categorical group comparisons, and ANOVA or Kruskal-Wallis tests if they're continuous data. We constructed models to predict the mortality and to assess the independent effect of hypercapnia using logistic regression as well as Cox proportional hazards. And as I said, this data was quite imbalanced between the groups, as I'll be showing you in my next slides. To account for that imbalances, we adjusted the data for patient severity at admission to intensive care, and propensity-based analysis to know the propensity of the patients to be hypercapnic acidotic, as well as we adjusted for the baseline GCS of the patients as well, because as you know, GCS is one of the important prognosticators in such patients. Further, we created a small subgroup of patients with exactly matched severity of admissions to compare the three diagnostic groups. And these things were done to ensure that we get to the truth as much as possible, given the retrospective nature of this data. These are the results, and as you can see, we started up with nearly 580,000 patients. It's a fairly large number of patients. But when we ended up with all the exclusions, we still had about 30,000 patients, making this the largest study of such group of patients. And out of these 30,000 patients, 13,000 patients had normocapnia and normal pH. About 1,300 patients had compensated hypercapnia, and about 16,000 patients had hypercapnic acidosis. This is a busy slide, but I thought I should show you because this slide demonstrates the fact that these three groups have imbalances in their admission characteristics as well as the severity of illness. Some of these differences are quite significant statistically, but perhaps they are not significant clinically. But given the large data set, it appears that it is significant statistically. So given these imbalances, we used that sophisticated statistical techniques. This is the data on the primary outcomes, primary and secondary outcomes, and these are all unadjusted values, and it's not surprising that these values are quite different statistically. Patients who had normal pH and normocapnia had better outcomes as compared to hypercapnic acidotic patients. This is the survival curves, and again, this demonstrates the same finding that patients who had normal pH and normocapnia had better outcomes. This is the most important slide of the talk, and both the logistic regression and Cox proportional hazards say that patients who have hypercapnic acidosis have worse outcomes as compared to normocapnia and normal pH or compensated hypercapnia, and this is across all the three diagnostic groups. But what is important in this study, in this slide, is if you have compensated hypercapnia, your outcomes adjusted to the confounders are not particularly different different as compared to patients who had normocapnia or normal pH, and that's consistent across all the 3 diagnostic categories. This is again further a sensitivity analysis matching the patient's admission severity, and this confirms the findings of the previous slide, which again tells that if the hypercapnia is compensated, then it's not as bad. If it is not compensated, then it is really bad. What is interesting is, if you look at the outcomes in comparison to the increase in hypercapnia, if you are acidotic and if your CO2 is raising up, your mortality increases, that is unadjusted. Even if you adjust it for the confounders, still the mortality rises if your CO2 is, if you are acidotic. If you are not acidotic, irrespective of how high your CO2, your odds of hospital mortality is not higher. So to conclude, hypercapnic acidosis in our study was shown to be associated with increased risk of hospital mortality in patients with cerebral injury. However, if hypercapnia, when it is compensated to normal pH, it may not be harmful in patients who are mechanically ventilated with cerebral injury. I thank you for attention, and if you have any questions, I would like to answer them.
Thank you. The audience seems to be moving further to the back. Any questions? No hands? Well, I'll take the opportunity again then.
You don't have to.
I'm dying to. One thing, I guess, the question that springs to mind from this observational study is what might happen if we correct pH, for example, with sodium bicarbonate in those patients who are acidotic in the first 24 hours, but whether that might change outcome if it's the acidosis that seems to predict poor outcome.
I think it is plausible, but obviously, we can't predict it because we don't have that data, and perhaps, future studies may look into intervening or preventing the acidosis. But our key message from the study is that we should not be looking at one value, and we should be looking at the value in conjunction with the overall picture, which is linking pH and PCO2 together, and these are very closely linked. And if you ignore one thing, it's not good for our patients. And I was rather surprised when I looked at the data that none of the recommendations bother recommending a particular pH target when you are targeting CO2. If you look at the guidelines, they just say that you try to maintain your CO2 between 35 and 45, and that's easy to do perhaps when you are ventilated, but it comes with a cost. For example, if you want to ventilate them harder, it can cause ventilator associated lung injury, and more importantly, if you make the patients alkalemic, then it can shift your dissociation curve towards the left, and it can reduce the oxygen offloading at the tissue level, so on and so forth.
I have one. The other microphone. Are you planning any interventional studies following on from this observational study, or what are your plans after this?
I think there should be some further studies to make sure that if we intervene or if we prevent this, whether the outcomes are going to be beneficial. But I guess that would be the next step. Yeah, absolutely.
Any questions from the floor? I'll ask one more then. I may have missed it, but were you able to discern any difference between those patients who remain acidotic and hypercapnic in the first 24 hours and those who adequately compensate? Was there additional injuries, age, disease factors that meant those patients remained acidotic for longer?
This is one of the limitations, and obviously I did not show the limitations and strengths because we did not have the time for that. The reason, this is a retrospective database, and we don't know why some people had that compensation within that first 24-hour period, whether they had a bit of delay in admission to the intensive care, and during that time they compensated, or whether they had perhaps pre-existing chronic hypercapnia that ensured that compensation by the time they came into the unit. So we really don't have that data, and that would be quite important to further understand why that happened, and whether it has any implications.
Okay, thank you.
Thank you.